Strive is a research consortium led from the London School of Hygiene and Tropical Medicine with partners in India, Tanzania and South Africa, and other associate and partners in the US and Uganda. We investigate the structural drivers, the structural forces that shape vulnerability to HIV. And a lot of our work revolves around identifying the kinds of interventions, the kinds of pathways of risk that can be intervened in through structural interventions. And one of the strong messages that we like to develop is the potential for synergies between broader development and health goals, the SDGs, for instance, and some of these more upstream HIV interventions. The question always arises, who pays for this? How do we get out of siloed financial allocations that are very strongly sectoral to make sure that we're paying for the benefits that accrue to different sectors? And here, this is an area that Strive's work, in which Michelle's been extremely central, has had a lot of impact, at least in the concept of co-financing. So Michelle will explain that in the course of this presentation. Michelle is an assistant professor in health economics at the London School of Hygiene and Tropical Medicine. As you know from our invitation, she's worked for 12 years on the economics of HIV and health financing within the United Nations system, in the Dutch government, and as a consultant and within research institutions at international and country level. She's been doing work primarily in Tanzania lately, and her main research focus is on HIV financing, and specifically resource allocation decisions for interventions with multiple cross-sectoral outcomes. Thanks so much, Michelle. And over to you.
Thank you very much, Annie. And yeah, good morning, good afternoon, good evening, everyone, wherever you are. So I'll be presenting this study, which is part of our work stream within Strive on co-financing. And as I think Annie has already said quite clearly about Strive, we've been focusing on trying to understand the structural drivers of HIV, and we've also been designing and evaluating the effectiveness of interventions that address these structural drivers. And then the question comes of, once you find effective interventions, how are you going to make sure they get prioritized and financed? And a lot of one of the issues that comes up, at least, is that a lot of these interventions, being upstream, have other development or health outcomes. And when we look at them from our HIV angle, we tend to only consider their HIV benefits. So we may end up not prioritizing them or undervaluing them, at least in our assessments, and they might not be funded. So this co-financing approach came out from that realization, and we proposed that it might be more efficient to actually look at it from the perspective where different payers and sectors could actually pool their resources to make sure these interventions get financed and implemented at scale. But whenever we present the idea with policymakers and have discussions with them, the question will invariably be asked of how can we operationalize this? And so here I'm going to present some findings from a qualitative study we conducted in Tanzania, which was really about getting the perspectives from policymakers and decision makers in a country setting on how feasible co-financing would be and what might be the barriers and actually more interestingly, probably also the enablers to such a financing mechanism. So just the background to this work has been very much this broader context of the new landscape of 17 highly interconnected sustainable development goals that require new integrated and synergistic approaches. And obviously health is currently just one of the 17 sustainable development goals, but the social determinants of health feature quite prominently throughout the development agenda. And we've seen in the HIV response how critical social drivers are in shaping HIV risk and service uptake. And there's also increasing attention to structural interventions that have been found to be effective for HIV. But given their nature, a lot of these interventions also have other health and development objectives, and actually a lot of the times these other health and development objectives might be their primary objectives. And it's because of, as I was mentioning, the single outcome focus we take in when we think about value for money, we may end up undervaluing and under-prioritizing them. So to overcome this, it's been proposed that pooling HIV financing with other budgets could be more optimal and could avoid crowding out programs which have spillover benefits. So I just want to, sorry, I'm going a bit too fast there. Just want to illustrate this here with this is what we call the bookshelf metaphor, which we've borrowed from Collier. And it's used to kind of illustrate how we can think about prioritizing different interventions in a health context. So here what you're seeing is a bookshelf with books, and each of these books represents a health intervention. And the interventions are ranked by their health productivity from left to right. And essentially they're funded until the health budget is exhausted. So that's the vertical yellow line. So as you can see on the left axis, you basically have health productivity, and on the y-axis, y-axis, and on the x-axis, you have health expenditures. Now, unlike the red books that we have here, which are only, or pink, depending how you see the colors, which only have health benefits, the blue book in this example has both health and education benefits. But when you're looking at it from this angle, you're only seeing the health benefits, and because of that, it would not make the cut and would not be included in the health budget. Now, you could look at the same picture from the perspective of the education sector, so the education bookshelf, really. And again, the education bookshelf, the education sector would not prioritize the blue intervention, so the intervention with both education and health benefits, because if you look at it only from an education perspective, considering education productivity, it would not look that productive, and it would not compare favorably to the other alternatives. So essentially, the conclusion here is that intervention 6 would not be funded. But if we assume that this intervention has equal education and health benefits, and therefore its costs could be shared equally across both payers, what we could end up seeing is that actually the cost of the intervention for each sector would be halved, and what you're seeing here is essentially the productivity would double, essentially, for each sector. And in reality, the health sector would have been better off financing half of that intervention rather than the intervention 5, which would have created a loss of health, which is this black area in the figure. So co-financing would really be a way of preventing welfare loss, so preventing losses of quality and quantity of life from a healthcare perspective, and from an education perspective, the same would be true. So you'd also be able to avert any losses to education in terms of education benefits. So that's one way of illustrating it. Another way, and this is probably what you might have seen already from us from our Strive work, is this. So this is the Samba cash transfer intervention, which was implemented in Malawi. It was a cash transfer that was given to, that was provided to girls to keep them in school. It was about $10 a month, and part of it went directly to the girl, the other part went to the guardian. And it had no HIV component. I just always want to highlight that. It was really just a cash transfer. And after just 18 months of implementation, among the girls who were in school at the start of the intervention, there was a range of benefits and that you can see here. So the one that we talked a lot about in the HIV world was the 64% reduction in HIV risk. But in addition to that, there were education benefits in terms of reduced school dropout rates, reduced early marriages, HSV2 risk, and teen pregnancy. And so, but then when the authors of the study did a quick cost-effectiveness analysis, they concluded that it would not be a very cost-effective intervention for the HIV budget, because it would cost between $5,000 and $12,500 per HIV infection averted. which would not compare favorably to the alternative prevention interventions such as male circumcision, for example. So then it probably would not have been prioritized by the HIV sector. And taking that perspective, the other sectors might have concluded the same. Education might have been able to say we can achieve the same benefit by doing something else. And the gender sector, the sexual and reproductive health sector might have said the same. And at the end, you could have still retained and achieved the same benefits. But the society as a whole might have ended up paying more than it would have paid for the cash transfer alone. So we illustrated through this example and with some numbers, the actual numbers from the trial behind it, that if they had co-financed the intervention, they would have come out with a more optimal financing outcome. Now, as I was saying before, the question is then always, well, okay, how can we actually operationalize this? Because we all know how challenging intrasectoral and cross-sectoral coordination and budgeting can be. And so we set out to conduct a study in Tanzania to understand the institutional feasibility, the barriers and enablers to adopting a co-financing framework in HIV resource allocation. So very briefly on the method. So we took a case study approach to elicit insights and perceptions from decision makers that are directly involved in planning and budgeting at the national level. Data collection was between December 2015 and 2016, and data was collected through in-depth interviews with 20 government officials and senior advisors among key development partners, with a focus on the HIV, health, social protection, and food security sectors. And the reason for focusing on those sectors was because of the underlying study we were embedding this within was had an HIV and health angle, but also had a social protection and food security dimension. The study participants were these policymakers that were purposely selected based on their involvement in planning and resource allocation, and there were a few that were also involved in sector coordination. And the interview guide was really exploring principles that were used in resource allocation in these different sectors, and how they might apply to cross-sectoral programs as well as to some form of application of co-financing. And then also trying to elicit from the policymakers what they saw as the barriers and the enablers to co-financing. So a bit of context. I saw there were a couple of people on the line from Tanzania, but just briefly, Tanzania is a low-income country, deep poverty in certain parts. There's a generalized HIV epidemic of about 5% prevalence, and also heavy donor dependence in social sectors. And this is important to highlight, particularly in the HIV subsector, where 98% of the financing, according to the last public expenditure review, was actually externally financed. And public services are financed by the central government, but increasingly there's a devolution towards decentralized authorities. Now, there's one program in particular that I want to highlight because we used it in the study to guide the discussions and to make them as real world as possible. So to avoid ending up in very hypothetical discussions about how feasible co-financing could be, we tried to really frame it within the context of a program that the government is currently implementing, which is called TASAF. It's the Tanzania Social Action Fund, and it has several components, but it's really meant as a social protection program, of which one base component is to provide a conditional cash transfer to the poorest 10% of households. It's currently reaching about 70% of target villages. It was scaled up at quite a remarkable pace, actually, and it's performing very well. In the pilot phase, there was an evaluation that was conducted, and they found positive impacts of the scheme on girls' school completion rates, on reported morbidity, on membership of the community-based health insurance fund, which is a big pillar of the Tanzania health financing strategy, and improvements in agricultural asset ownership. So these are just important to highlight because they obviously cut across different sectors' goals. And so this type of program would be the type of intervention you would expect could be co-financed across different payers. And importantly, there is the actual context-specific, there was context-specific evidence that we could refer to during the discussions. So on to the results. I think one important thing that came out of this is a lot of our work on co-financing assumes, and actually a lot of work in health economics and cost-effectiveness analysis assumes that decision makers are trying to maximize outcomes, that is their primary objective, and that is they're trying to do that subject to their budget. So they're trying to get the most out of their budget as possible, focusing on the end outcomes of relevance to the sector. So for the health sector, we'd be trying to improve life expectancy, reduce morbidity and mortality. But in reality, in a lot of the discussions of trying to understand how resources are allocated, how priorities are set, policymakers highlighted that they are actually maximizing service outputs. So these are measured as the number of people reached with certain services, for example, or the coverage of certain services, rather than really thinking about life years saved, for example, in the health world. This is important because it does reshape a bit how we think about co-financing. In terms of resource allocation criteria, there are, people mention impact and evidence, but actually a lot of decisions around what a specific payer is going to allocate their money to is dependent on their comparative advantage, that came up a lot, on the feasibility of implementing a certain intervention, on the historical allocations of how much a certain program or disease area or certain intervention has been getting in the past. Often year on year, you just look at the past budget and maybe add on a few percentages. Another criterion was the reasonableness, how reasonable a budget seemed, how reasonable in terms of what they were expecting to achieve, and also just the financial guidelines from central levels or from the organizational center. The geographic focus was another criterion, the sustainability. And a few people mentioned costs, but more as a constraint. Actually, only very few discussed the cost in relation to their impact. So the idea of cost effectiveness was really not central as a resource allocation criterion. Another important finding relevant for co-financing was that ministries were mentioning their instrument a lot. And in Tanzania, I had not heard the term before, but essentially it refers to the mandate of the ministry and the ministerial responsibilities that they had been assigned by the government administration. And this instrument essentially limits them to interventions that are delivered through their service platforms. So, for example, the Ministry of Health is mandated to meet impact level health targets, so that it is part of their mandate to improve life expectancy and so on. But they can only do so by ensuring the availability of and access to quality health and social services. So just an important additional constraint to bear in mind. And through the discussions, what did come out quite clearly is that the different sectors or decision makers we were talking to actually were reflecting different types of payers. So you had some who could be classified as pure purchasers in that they had a single objective and they only had a budget constraint. So this was often donors because they were less, they had fewer other constraints, and they could focus on single issues or on specific issues and really were quite results focused in that sense. And then also local government authorities at the more decentralized level appeared to have less of these other constraints limiting where they could put their resources. Then you had purchaser service providers who had both the role of purchasing outcomes but also providing services. These were the line ministries typically. And then you had pure service providers. So some of the payers we realized were funded to provide specific services only. So these are some multilateral organizations, some government departments. So they weren't really able to choose where money between different types of interventions to allocate money to. Here are a few quotes just to bring in the voice of the policymakers. I think one important one which came up a lot, and I've just pulled out one quote here, is that resource allocation is not entirely rational. I think we all know that, but here there's a quote that it's not scientifically based. What we contribute in different areas, it also comes in politics, and this is both among government and among development partners. Ministries also have very specific objectives, and one government official was mentioning that externalities, so spillovers that happen to other sectors, are not going to be taken into account by a line ministry. And also just a reminder to those of us working in the HIV world that the HIV funders tend to be very single outcome focused, and non-HIV outcomes are unlikely to be considered. It's all about the HIV outcome. Now, what I thought was very interesting is when asking policymakers whether they thought co-financing, so transferring essentially budgets between one government department to another, or from donors, for example, to different pools of funding, a lot of the government officials responded positively, and a lot of them, there were people were saying things like, "Yes, it's possible. Why not? You can do that," which I thought was quite surprising. And actually, there were even cases where this had already happened in some form, or it was being seriously considered, particularly in the context of TASA. So in the past, for example, TACAIDS, which is the National AIDS Control Coordination, the National AIDS Coordination Committee, was actually allocated some resources to TASA with clearly an HIV objective to sort of build in more HIV sensitivity into the social protection mechanism. And so that could be seen as obviously having been some form of co-financing. The UK is also funding TASA. But interestingly, the source of funding coming from the UK, a large part of that is from an environmental fund. So the program itself is not, it's not entirely, it's not purely an environmental program with environmental objectives, but it does have a spillover benefits to the environment and climate mitigation, and so they've clearly bought into the program based on that objective. So that can also be seen as some kind of a form of co-financing. So it was interesting to know that the concept is there and is to a certain extent is being applied in some form. What came out also quite clearly is when we are thinking about co-financing, and you might have seen in the previous learning labs or previous work we've done, a lot of what goes into figuring out how much each sector should put in is based on what each sector is willing to pay for their outcomes. And this is the WTP, the willingness to pay concept is actually quite central to establishing those different co-financing shares. And what it means really is how much is that sector or that payer currently paying by doing other things to achieve those outcomes. And we were trying to get to see whether the policymakers and decision makers had a sense of what that number was and whether that could guide them in deciding how much they could allocate to a program that would be co-financed. But quite clearly, this willingness to pay concept, or this idea of how much you're currently paying for your least efficient investment, is not it's not explicitly or implicitly used in resource allocation. That's also not too surprising, but it was interesting to note that many people did have a very clear understanding of what willingness to pay represents, in that it's an opportunity cost, it's the alternative use of resources, and it reflects your ability to pay. What decision makers also had quite a good sense of is how they would implicitly rank different investments. So if we remember our bookshelf, they did have an idea of which interventions they felt were more productive than others, and a sense of which one they thought was least efficient. Obviously, that least efficient investment did not appear to be based on any explicit analyses, but they did consider the certainty and the effect size of the intervention's impact, and also how costly the intervention was compared to its benefits. So that was in the back of their mind when they were thinking about that ranking. And here again are some quotes from the decision makers. As you might expect. As an economist, I got quite a pushback to questions about how much you'd be willing to pay for things like, an infection averted or a life saved, which I can understand. Obviously, it has willing to pay tends to be seen and have quite a moral value. As you see here, that's a very unfair question. If you're asking me, would you spend $350? Of course I would. Would you spend $500? Of course I would. But then clearly, then the thinking went on and sort of bringing out the issue of ability to pay and how we're actually talking about opportunity cost. So, but do I have it? No. If I had it, I would spend it. And also this idea of disinvestment, because actually really when we're talking about co-financing, you are saying you'd be willing to take money away from your least efficient investment and put it towards this pooled fund. So you are going to be disinvesting somewhere, or even if it is new money, you are spending it on this rather than on something else. But obviously there was a lot of reluctance to using any term around disinvestment. So this government official is saying, I would not disinvest. Rather, maybe I'd integrate programs so that we can have savings. Now, just to summarize a bit what came out around enablers and barriers, a lot of people mentioned, it came out actually quite consistently throughout, that in order to make something like this work, you would need to have evidence both of mutual gains, so it must be clear what each payer or which each sector is going to be benefiting, and also cost savings. This was seen as the key driver of bringing people to the table at all. The second enabler was strong political will and the need for champions or advocates that would actually push this as a financing mechanism. Quite a few people were mentioning that it would be more effective if it was embedded within an intersectoral governance mechanism that would facilitate the financing and the transfers, but also that would ensure accountability, and that was quite key. The last enabler, which I thought was also very interesting, is actually reflected in the literature from other settings, is that payers with a population focus or a very strong results focus might be more likely to engage in co-financing than others. So, for example, decentralized payers at a kind of local government level, it might be easier for them to be thinking beyond the silos and really focusing on what are the needs of the population, regardless of the sector, and to allocate resources based on that, rather than at the more central level where responsibilities and mandates are more siloed. And the same seems to come out for donors. So donors that are more flexible to a certain extent in where they put their resources and also tend to have a stronger results focus, well, in some cases, not always, but could, for example, in the HIV world, there is a very strong focus on the HIV outcomes. That might be an opportunity in many ways to actually justify a co-financing mechanism. But then, of course, there were barriers. In the context of Tanzania, several people, government officials as well as development partners, mentioned that there are very limited discretionary budgets to move around. So the fact that, after all, the more harder commitments are funded, like salaries and so on, there's very limited budgets that can be moved around, and this was seen as an important barrier, particularly for government budgets. There's also limited financial autonomy, so many funds that come both to government and also to some non-government organizations or multilateral organizations are earmarked for specific purposes or specific interventions, so they cannot be moved and redirected to other interventions just on the basis of their outcomes. Also, now thinking more from an institutional perspective, many people were mentioning the individual barriers that would, or disincentive there would be to losing control of one's budget. So a budget holder would be reluctant to that because, which is in line with a lot of political economy theory, which shows that actually many bureaucrats are actually trying to maximize the budget that they control, because that reflects the power they have within the system. So that's likely to be an issue. And the last barrier was, and it's linked to the other one, is really this loss of visibility that might come from co-financing and from transferring funds to another implementer, another sector. because you then lose your claim on the outcomes, and this might reduce your ability to justify your existence in some way and to raise additional funds later and mobilize resources based on your track record and what you've achieved. So a few quotes on these points. As you see, this enabler of the need for a buy-in at a high level and champions very solid, very clear analysis of who is getting what. So this point about clear gains. And then this idea that evidence will really be central. I'm telling you the truth, it is the evidence. If it works, the modality of how we do it is not an issue. But then, of course, the barriers. So the major challenge is that the resources they get is not even enough to meet their need. So this is someone talking about particularly the health sector. And also this institutional resistance to change, resistance to losing power, which multilateral development partner was mentioning. Oh, sorry. Yes. So those were the main findings. Just want to make a few points, raise a few points around the study limitations. I mean, obviously these reviews from a small sample of national level decision makers in specific social sectors, so they might not reflect the views of overall of policymakers in Tanzania. Some of the insights also you could say were quite hypothetical, although we really tried to keep grounding them in real programs and real financing. You can imagine that a lot of discussions were just about, could it work? How could it work? And this may therefore not be predictive of actual behavior that policymakers actually exhibit in a real world situation. Also, just to highlight, I mean, as my role as a researcher and a part of the study, it may have led to a desirability bias. Not sure what happened to my slides here, but so obviously I think that might have influenced why the role of evidence came out very strongly. That might have been a slight desirability bias there. Also, just a point that should be a sub-point here, but the study was conducted in quite a specific post-election context, which was characterized by substantial uncertainty about the new government's priorities and some reserve among respondents. Because there was a new president, this bulldozer president, who took office in the first phase of data collection and really set out to radically change government's business as usual and kind of transform public work ethics and increase efficiency. So this may have led to more openness about new ideas around efficiency gains, but also may have restrained some respondents' sense of control and ability to respond. So that's just to caveat a little bit the findings. But still, I think the findings are unlikely to be unique to Tanzania alone. Just for one, a lot of the development organizations operate globally, and so they'll be influenced by similar global agendas and organizational constraints in other settings. And also governments in high-income countries who have put in place cross-sectoral budgeting or coordination have also had to tackle similar barriers and resistance that was mentioned here. So it is reflective of the broader literature in this area. Just a few concluding points. So cross-sectoral co-financing could be operationally feasible. People did not bring up any major barriers for it to actually, be operationalized within the system or actually changing financing flows and budgeting within government. So it seems to be operationally feasible, but it would require refocusing the decision frame we have at the moment in co-financing around achieving service outputs more efficiently rather than service outcomes, although that might have come with some risk. But in terms of initial operationalization, that probably has more potential. It could also be operationalized as a catalytic mechanism, which could be used to tweak certain multi-benefit interventions instead of relying exclusively on mainstreaming, which has had mixed, results, but rather to use co-financing as a way to trigger changes in certain programs that could be made more HIV sensitive, for example. But, obviously the institutional incentive structures and political factors are likely to hamper voluntary uptake, and this was found in other settings as well. But respondents highlighted specific enablers that might incentivize and mandate cost sharing. those would be areas to further investigate and to try to tap. But clearly there's need for more research and more specifically more operational research on co-financing experiments in low and middle income countries to investigate, on the one hand, how effective these models are at realizing efficiency gains and multiplying impact, but also to understand better where in terms of in which context and how they're most likely to be institutionally acceptable. And that's the end of my presentation. So thank you a lot for your attention and look forward to your questions.
That was really, really interesting, Michelle. We've had quite a lot of discussion within Strive about this model. So to have this really specific insight into how it may play out in reality, I think is hugely interesting and gives us lots to think about and discuss. I think that I'm of the opinion that participants in this call are a mix of people who are economists and people who work in research or in implementation. So I think we're probably going to have different kinds of questions about either the model or this particular piece of research. So please do unmute yourself by pressing *7 if you have a question, or raise your hand in the box there, or type your question into the text box on the left of your screen. Meanwhile, I had a few questions or comments. Just a small point towards the end. You talked about tweaking in your conclusions, tweaking rather than aiming for mainstreaming, which seems to me to open a whole avenue that applies to this study and this work, but also to many others. And I wondered if you could give examples. I imagine that the cash transfers would be one, but if you have other examples that might clarify that, Michelle.
Yes. So I mean, I realize this might be a bit controversial, but I think there's been there's been limited success with mainstreaming, but that might be just my opinion and experience I've had in country settings trying to do this. But also, I think that basically using a financing instrument as a way of triggering or tweaking certain programs in order for them to actually basically to mainstream HIV, or other issues, might be a more effective way to go. So, for example, if you have a social protection intervention, rather than trying to convince them, the ones implementing the intervention to target a specific HIV-relevant group, for example, or at risk or people living with HIV, just out of their own recognition that should be part of their mandate and part of their objectives, you might be more effective if you have some money to put in based on the benefits that you see you would get from that investment, and put that in as a way of triggering that change in the program initially. And it may mean you have to keep paying in because you need to keep paying in for those benefits, or it may mean because of that initial tweak that later on the program will continue to be implemented that way, whether you're funding it or not. And I think that was probably the rationale that TACAIDS had as well in Tanzania initially when they put in that money into TASO to try to trigger that change and to leverage that broader program for HIV objectives.
Right. So when you say you would put the money in, you meaning a ministry, a development partner, a donor, that finance would come from coming in with sector or okay.
Yeah, coming from with that objective in mind, basically. Yeah.
Right.
But I'm very curious to hear what others think.
Me too. So do speak up, everyone. I was also interested in early on. You talked about policy making as a political. It's a political process, and you referred to that right at the beginning and also again in the conclusions. For example, looking at questions like having budget control and so on, and also the context. You referred to the post-election period when you were doing the interviews. And I wondered how it's one thing to take that into account in research, in a research study like this, but if there's a way in developing the model of making sure that those discussions and that analysis of the context is part of the process of considering co-financing, because to make sure that people are looking for opportunities and understanding the various forces at work rather than trying to apply something very schematic. But I guess that plays out in practice anyway.
Yeah, no, absolutely. I think, I think the objective of the modeling and putting the numbers is really as a starting point for the discussion and to bring people to the table in reality. I don't think in practice that's exactly how these, the different shares and contributions are likely to be determined. So I think that is part of that next phase of kind of the operationalization. And we've been doing some work with UNDP, who is actually trying to support countries to operationalize or to experiment with some of these, with this co-financing principle and to apply it. And they are very much trying to build in, at the initial stage of exploration, to really build in an institutional context analysis, which is really looking at these different political factors and trying to identify, where are, how likely is it to be, what are the risks, and what can we do to mitigate those risks, or if not, maybe this is not the best place or the best intervention or best sectors to be starting with. So that's definitely part of the thinking for those who are working on the operational side.
That's great. I think that's important to emphasize somehow. There seems to be, not in this work, but often a gap between the realities of policy making and also whose decisions around the finance. You did raise that at the beginning, talking about how much of the spending on some of these programs would come from donor budgets. I also wondered about, unless someone's got a question, I'm not seeing any, about terminology and language and the question of framing this a certain way. You used the term spillover a couple of times, spillover, and obviously there was reaction to to framing this as disinvestment as opposed to more strategic investment or something like that. I thought that was really interesting maybe that's just my interest, to reframe things rather as mutual benefit rather than spillover. Or just the terminology of framing.
Yeah, no, I think the framing is really critical, actually. And I've also noticed over time, as we've been doing this work, we've been talking about framing and language as well. But I think also in the in-country discussions and work that UNDP has been doing, I think a lot of the framing tends to be around cost savings, actually, and mutual benefits as well. But I think it is coming from a more of that efficiency and kind of cost-saving angle. So it's interesting to see what speaks to different stakeholders and to different audiences. But I do think it is really important. And I think the other example for us doing the study was also in terms of how we talk about this willingness to pay. That framing definitely does not go down very well with many policymakers. Particularly in the health sector.
Yes, that's in your quote.
Yes. So I do think that's really important. But I do think once you get past that point, and that's what was coming out quite clear. People do see the underlying point and are of course taking it into account and thinking about it. So it is really critical when having these discussions and really trying to be talking about the same thing. The framing is important, and I'm sure it will be very important in any operationalization.
I'm aware that I'm possibly pushing the conversation in a certain direction because I'm interested in research uptake. But I was interested in the point about a mechanism that ensures accountability, but also puts this whole idea of co-financing on the table as a legitimate rather than weird experimental side thing that people could buy, that shapes the thinking around it. And I wondered how realistic that is, or how likely you feel, and also where you have to, at what level you have to pitch that idea. Is that a central sort of treasury level, or I suppose it depends really. I suppose it depends on who is getting behind this idea and would want to take it further in government structures.
Yeah, I mean, again, I think the experience from UNDP will be interesting as it's rolling out, and I think it will depend on different country settings. But part of what was coming out of this was it might be more of a there might be more potential if you enter into a mechanism that already exists. So, for example, if there are intersectoral coordination committees on specific issues, so for example, for social protection, there is one in Tanzania for the HIV response. Of course, there's also always been a multi-sectoral approach. So nutrition, for example, would also have already, established kind of intersectoral working groups, which already brings different stakeholders together to achieve. The slight difference there is that you're bringing different stakeholders together to achieve one same objective, whereas co-finance is actually bringing different stakeholders together with different objectives and recognizing those, and then trying to bring them around one program that will allow them to achieve those multiple objectives. So it's slightly different, but I think at the end you still have the same stakeholders at the table, and it's really about, I think, making the case to them that there are mutual benefits, and ensuring that that mechanism is already there will help for the accountability, because there would be a plan, there would be some kind of, monitoring and evaluation framework, and some way for them to come and hold each other accountable, especially if you're putting money, or your own money, as a sector or the department into this other sector or this program. So that seemed like an important place to start, or especially at this stage where co-financing is still, not particularly established or anything, that would be maybe a more fertile ground to initiate something like this. The other area which came out, and I was trying to point to it, was that, again, I was only talking to people at the national level, but many suggested that there might be more potential at the decentralized level for this, because there are less silos, because they get funding in a pool form actually down to that level, and they can decide how they want to spend that money based on the priorities and the issues in their specific localities. So that might be an area with slightly less siloed approach to prioritization, and where this kind of thinking might be more easily reflected in their decisions. So I'm not sure. But there are a few bits and pieces of ideas of where you might start and what might be your entry points. And this has also been, it is reflected in some of the literature from high-income settings, where they have actually tried to implement, or they have implemented these types of joint budgeting mechanisms.
I think all of this adds up to understanding how, a better understanding of how this can move into practical application. So from the question of the tweaking to utilizing, influencing mechanisms and levels of budgeting that are already in place. So I think it's hugely valuable, because these are always the questions that we face, is how do you make this real? And this starts to, how do you make something that has such potential? How does that come into implementation in reality? And I think this makes a huge, helps us enormously in that direction, so that's great. I imagine that there will be lots more questions once people are back in the arena in the new year. So I look forward to taking the discussion forward within and beyond Strive. I'd just like to say a huge thank you to Michelle. This is extraordinary and interesting work, and it's been great to have it explained so well. So thank you.
Thank you very much, Annie.